The content discussed in this episode may be specific to the guest's organisation or location and may not be applicable to other organisations, states, territories or countries. The material presented in this podcast is for general information purposes only and should not be considered health, legal or financial advice. Medical administration is a rewarding profession, but it comes with challenges. So what is it like, and what should you do if confronted with a monumental administrative difficulty? This is the podcast that takes unfortunate scenarios and explores the essentials of clinical governance to find solutions. I'm Dr. David Rankin, a very experienced medical administrator and lead fellow with the Royal Australasian College of Medical Administrators. And this is Safeguarding Healthcare, the essentials of clinical governance. Today we have a fascinating scenario that would sink the heart of any medic.
This patient has complications of having the wrong operation done.
That's Dr. Helen Parsons, the District Director Medical Services for the Nepean Blue Mountains Local Health District. And I'm presenting her with a nightmare situation.
They're going to have to go back and have the correct operation done at some point, which increases their risk of complications and comorbidity. And I'd regard it as serious harm.
In this episode, Helen will outline what should happen after what's called a wrong site surgery. A theatre unit manager calls to say that a surgeon has just undertaken a gallbladder procedure on a patient who was booked for a hernia repair. Unfortunately, the patient has developed complications and is being transferred to the intensive care unit. There was apparently a late change in the order of patients on the theatre list. This is a very nasty complication that haunts many of us as medical administrators. I started by asking Dr. Helen Parsons what concerns an incident like this raises.
Well, I'm seriously concerned. This has been an incident involving wrong site surgery. This is a serious medical error and has the potential for harm. It's got patient safety implications, ethical considerations and legal consequences. I'm obviously concerned with the patient and their well-being and how we can get them appropriately treated, but also looking at the immediate, medium-term and longer-term, what has actually happened in our system that has actually allowed this wrong site surgery to occur. And there's also legal and liability issues involved in this. Also, our reputation of the hospital and the trust of our community in the care that we provide. Certainly, the patient and the family will be affected, but also staff will be affected. They will be very concerned and upset and disturbed that this has actually happened.
So let's start with the process that should be in place, I guess. What sort of steps would the hospital normally have gone through to make sure that this type of thing doesn't happen?
Well, normally when a patient is having a procedure, it would start from when the surgeon sees the patient. There is a process of informed consent, clear explanation of the type of procedure, the complications of the procedure, and an informed consent process, also using interpreters if that was necessary, and also if there's any concern about the capacity of the patient, appropriate decision makers or processes, for example, guardianship boards, etc., be used. There's also the transfer and communication of that consent and the recommendation for admission through the booking office, the patient's admission, and then through the theatre process, where there should have been the checking of the patient's identity, the procedure and the consent to that procedure right through till we get to the theatre, where the surgical, anaesthetic and nursing teams also check the consent and identification of the procedure, marking of the site, etc.
What are the immediate actions that you're going to take?
My immediate concern is firstly the patient.
Yeah.
I'd have to make sure that they were in ICU, that they were being cared for by the ICU team, that if they were well enough, that there was an explanation to the patient about what had happened and an apology given to the patient and an explanation of what was going to happen going forward with their care. Also, an explanation to the family members about what has actually happened and what we're doing to care for their family member. Also, I'd be looking at the surgical team, the surgeon, the anaesthetist, the nursing staff, and supporting them because they are very likely to be quite devastated by this incident.
Tell me about open disclosure. Would you tell the patient that things had gone wrong, and how quickly would you do that?
I certainly would be telling the patient that things had gone wrong, and certainly it would depend on the patient's condition, how well or how unwell they were. It may be if they are seriously unwell that they've been taken to ICU, they may not be in an appropriate clinical condition to convey that information to, but I would certainly be talking to the family members and also making sure that they knew who the team was that was treating the patient and that there was a member of the hospital staff that was their contact point that could support them through this process, give them my contact details as well that they can ring at any time, and really reassure them that we're going to actually seriously look at this incident, put a review team together to look at the incident to work out what, how and why this has happened.
Okay, tell me about this review team. What does it look like? What sort of things are they looking for?
Well, an incident such as this would normally be a serious adverse event, and certainly we would regard it as what we call a harm score 1, and the chief executive would make confirmation of that, and we would first of all have a team that would actually look initially at what happened in the first 72 hours and do what we call a preliminary risk assessment and report on that to the chief executive. And then we'd more than likely form a root cause analysis team, which would involve usually a member of the clinical governance team who's experienced with doing root cause analyses and members of similar departments and professions, for example, allied health, nursing and medical, and then also an external expert from another local health district who can participate on that root cause analysis team.
Sometimes there's a concern that the hospital might try and hide things. Would you have a patient advocate on that review team?
Yes, most certainly consumer representation on that team would be usual, as well as the clinical governance staff whose role is to look at risks in the organisation and assist in identifying risks, conducting root cause analyses and monitoring the recommendations that they are implemented.
So in trying to determine what level of severity, I guess, for it to be a sentinel event, it has to be wrong site surgery and the patient has to suffer serious or significant harm. Having your gallbladder out instead of your hernia operation, is that serious harm?
Well, this patient has complications of having the wrong operation done, but also they're going to have to go back and have the correct operation done at some point, which increases their risk of complications and comorbidity. And I'd regard it as serious harm.
All right, so you've decided that it probably is a sentinel event. Who do you have to report sentinel events to?
Well, Chief Executive, the Ministry of Health, the Clinical Excellence Commission, that's where they're normally reported to.
And what does the external agencies, the Department, the Ministry of Health or the Clinical Excellence Commission expect from you?
Well, certainly within 24 hours, notification of the incident through a reportable incident brief, and within 72 hours, notification of the preliminary risk assessment results. There is a committee at the ministry level that monitors all the serious events in the state and looks at the findings of the root cause analysis committees and will look at that particular incident, but also look at the trends across the state as well, and that we're actually implementing the recommendations. The other group in this that we report this to is the board of the local health district, who also monitor that we're implementing the recommendations of the root cause analysis team.
This is a sentinel event. Do you involve your insurers?
Yes. Obviously, if you have your own legal team, notify them immediately. and also the Treasury Managed Fund, or however it's termed in the jurisdiction, because it is very likely to become a medico-legal case.
All right. You've talked about all the affected staff, mentioned that there's the surgeon, the anaesthetist in the theatre staff who clearly let things slip through and feel devastated. How are you going to support them?
Through debriefing, through the process of the root cause analysis, they will also be conversations between the team in a very non-judgmental way, looking at systems issues. We also provide access to employee assistance people to support them. We can also do debriefs as well in the workplace, in teams, and also for the doctors concerned, have them notify their medical indemnity organisations, and their medical indemnity organisations will provide them with support as well.
If it's the first operation on the list in the morning, would you allow the team to continue to operate, or would you suggest they step down?
I'd be very inclined to get them to step down. I'd also, one of the thoughts that crossed my mind in this case is whether the patient who was supposed to have this procedure had the opposite procedure, and there may be a second patient involved in this as well.
One of the issues, I guess, is does this happen very frequently in your hospital? How can you work out whether this is just a single devastating event or something that happens, unfortunately, more frequently than it should?
Well, all incidents like this should be reported on the incident management system for the hospital, but that may not necessarily be so. I think auditing is a very big part of the process of trying to identify whether something like this has happened, and hopefully not so devastating, but whether this has actually happened in the past and how frequent it has happened in the past, doing retrospective audits, but also prospective audits as well.
And if you find that you've had near misses because of either theatre processes or the surgeon's always in a hurry or personalities, how do you go about changing that culture, I guess, in the theatre?
That would be of significant concern to me. I would certainly be looking at an educational process, not only the policies, procedures, systems and auditing, but also an educational process. And at some point, if staff who have an obligation to comply professionally, but also from an employee point of view, if there's a series of these events, then looking at their professional competence and their conduct, and whether that needs referral to regulatory authorities and or action taken within the organisation if there is non-compliance.
It's very easy for us to look at this as a mistake by the surgeon. The surgeon was the one that held the laparoscopic instruments. The surgeon was the one that took the gallbladder out. Is it just one individual here, or is it the team that should be held to account for what happened?
Well, obviously the how, what and why would be explored in the root cause analysis. Ultimately, the doctor has professional responsibility for the outcomes of their work, but it is, as you say, a system, and there's a Swiss cheese hole model where things slip through the holes because there's not enough checks and balances in the system. And certainly we need to actually try and put as many roadblocks in the system to make sure that things like this don't occur, but ultimately it is the surgeon's responsibility when something like this does happen.
You talked about a no-blame culture. How does a no-blame culture work to make sure that things like this don't happen again and the people involved are held to account?
Well, certainly the no-blame culture is, as you say, looking at the systems, policies, procedures, and trying to make that as safe as we possibly can for the staff, and putting in place, it's a bit like the aviation industry with all their pre-flight checks, that there's all these checks and balances in the system to try and prevent something like this happening, that we're actually providing a lot of education to our staff, supporting them in that environment, and also that the lessons learned from incidents like this are discussed in the department and spread throughout the community of practice.
If the patient or their relatives come back to you after the investigation and say there were things that were completely missed, I want to sue the organisation, how are you going to respond?
They have every right to sue the organisation. I would also be giving them the contact details for the complaints authorities in the particular jurisdiction because they are able to have that avenue. They certainly are able to go to their own lawyers, and I'd support them in that process. We obviously notified the government's insurer that this has happened, and also work with our medico-legal people to look at how to manage this as a medico-legal case as well.
If the patient wants a copy of the investigation, how do they go about it, and are you able to release it to them?
We are able to release information to them out of the report of the investigation. There is statutory privilege associated with documents, so it'd be something that I would be talking to our legal team about what actual documents can be released. But certainly the patients and their families are provided with the outcomes of the root cause analysis investigation.
From the root cause analysis, you come up with a whole lot of recommendations. How do you make sure those recommendations are implemented?
That's a very good question. As a result of the root cause analysis, there is recommendations and an action plan formed with timeframes and position holders responsible for implementing those recommendations. And the recommendations have to be practical and able to be implemented. That report is signed off and confirmed by the chief executive, and then having a small team that monitors that action log and monitors the implementation of those recommendations. So if it's policies, procedures, training, there's documentary evidence that they've been implemented, but also going on in time, there's the auditing process and going back and checking that those recommendations physically have been put in place. And the other thing I've used in the past has actually had consumer representatives from our community advisory committees, etc., go into departments and check that the actions that have been implemented are still in place.
It can be a real challenge sometimes when staff change, the incident gets forgotten about, and things revert back to normal. Patients are often very interested to know whether or not the hospital has implemented processes that would stop this happening again. Would you normally expect to report progress on the implementation of the recommendations to the patient or their family?
Certainly, I would be ensuring that we kept them up to date as to where we were with implementing the recommendations and also when we'd finalised implementing the recommendations.
Do you have any final thoughts about how patients in hospitals can be assured that these type of incidences are avoided?
That's another very good question. I think having, for example, hospital accreditation and the Australian Safety Commission national standards and the unannounced visits, get 24 hours notice of visit, I think that is an excellent way of ensuring that we minimise a repeat of this incident. Also having appropriate committees in the health service, like the Communicating for Safety Governance Committee, and making sure that the services and facilities where procedures are performed are doing the appropriate auditing to ensure that patients are consented appropriately, that the right procedure site is marked where it's appropriate, and the appropriate interpreters are available. Patients with cognitive impairment are appropriately supported through that process by the relevant competent decision makers. And also with the Communicating for Safety Committee, making sure you've got community members, representatives of the multicultural community, representatives of the Indigenous community on that committee. And they, speaking from personal experience, will certainly hold us to account for that.
And that brings us to the end of this episode of Safeguarding Healthcare, where I was discussing a case of wrong site surgery with Dr. Helen Parsons, the District Director of Medical Services for the Nepean Blue Mountains Local Health District. I'm Dr. David Rankin. Follow Safeguarding Healthcare free on Apple Podcasts, Google Podcasts, Spotify, or wherever you listen to podcasts. This podcast is produced by Sound Cartel for the Royal Australasian College of Medical Administrators.